Good morning, RN42 skills. I'm going to show you our NG tube checkoff in brief using my home mannequin, my box mannequin over here. So briefly, for the NG tube insertion, please review your concept maps, know the reasons that you put an NG tube in, and your contraindications and your complications before you go into practicing this skill. You should have your checkoff with you. And you can use at home a teddy bear, a doll, something like that to practice with. All right, let's get started. So of course you're going to enter the room appropriately. I'm going to knock, I'm going to gel in. Here's my gel. Introduce myself. Hi, my name is Melody Cox. I am your nursing instructor for the day. I'm going to be inserting an NG tube into your nair because we need to start some tube feeding on you. Now that's important to know the indication for your patient who's getting an NG tube because we have two basic types of tubes. I'm going to show you them here. One's a general feeding tube. Okay, it's just simple, floppy, has lines on it. And then we have one called a Salem sump tube. Now this one you notice has an extra blue piece. Oh, came apart, but it has two pieces to it. If you were to look down the bore of it, you can see that there's two pieces here. And this is actually used not only for feeding, but for suction. So let's say your patient came in for small bowel obstruction and they have an order for an NG tube placement to low intermittent suction. You would place a Salem sump, not a feeding tube, for a couple reasons. Note that the feeding tube is smaller and floppier. It's going to be easier to compress if you apply suction, and these are not made for suction. The holes at the bottom are small. See the holes? That's meant for crushed up meds, well crushed up meds, and feeding. This Salem sump tubing it's actually pretty rigid when you get it out of the container, but it also has a non-collapsible type of plastic here. This is the main entry point for the NG tube, but notice the side channel here. That is actually an air channel, and it allows communication from air from the outside from here all the way down in a separate channel all the way to the bottom. And the reason is, if you think about applying suction to a balloon, if we were to stick this inside your stomach and imagine it's a balloon and put suction, it would collapse the balloon and hold on. So you wouldn't be doing what you really want to be doing. If you allow a little bit of air in there, then you're able to apply that suction without collapsing the stomach. So it's important, if you're going to apply suction, you're going to be putting in a Salem sump. This blue thing really is the air channel here. So you have to make sure it's closed so it's not dribbling tube feeding everywhere. Remember, this is open communication from the stomach all the way to the outside. You will often see these clamped like this, okay? That just means the whole thing is clamped. If you have a tube feeding ordered for this patient in a few days, let's say their small bowel blockage is resolved and they can't take PO, so they're going to start some tube feeding for them, you can start tube feeding with this. That would be fine. It is a larger bore, harder plastic. It can be hard on your nares tissues, your mucosal tissues, so make sure you're looking for that pressure ulcer with any tube that we place in a patient. But those are the two basic differences. Feeding tube, floppy, smaller. Salem sump can be used for suction and for feeding. A little harder on the tissues, maybe a little bit easier to place because it is, it's not going to bend as much, so it will go down nicely for you. So in this demonstration, we're going to get out our feeding tube because we're pretending this patient is going to get a feeding ordered. So that's ready for me. I'm going to gather my supplies. Before I start this procedure, I will actually get a set of vital signs. I will auscultate the lungs and auscultate the vowel sounds. The reason those two auscultations are important is for a couple reasons. We want to have a baseline of what the lung sounds sound like, because a high risk for this procedure, if you're feeding someone, is that they could potentially aspirate feeding contents into the lung. So we want to know the baseline is. If they're already crackly, gross sounding, coarse, we want to know that beforehand and know that's not a change after the tube feeding starts. Bowel sounds, it's really important. If I'm about to feed this patient, they must have functioning bowel tissue. If they have absent bowel sounds, you cannot stick feeding in there. It will just sit and cause greater disruption. So you need to have functioning bowel tissue to be able to put feeding in there, okay? So I will apply the pulse ox too, because that will help me as I'm doing the procedure, knowing that I'm going down the right tube, as it were. All right, so I'm going to explain the procedure to the patient. The position for the patient is going to be high Fowler's. Get them as high up as possible, as comfortable for them. Almost 90 degrees would be appropriate for most patients. Definitely don't have them slouched. So sitting straight up, not slouched. It will help them flex their neck well. We're going to first examine the nostrils and select the most patent nostril by having the client breathe through each one. So I can go ahead, after I use my gel, I can put on clean gloves because this is a clean procedure, not sterile. Generally, things that have to do with the GI tract are clean because technically it is outside of your body, right? It's a tube. Okay. Excuse me. All right, so I'm going to inspect my patient here and press one nair and say, can you breathe through that one? Can you breathe through that one? Have you had previous trauma to your nose where your boxer, nose ever broken, things like that? And then you could shine a light and take a look if you'd like, but really the breathing patency is important. We don't want to, if they can only breathe through one nostril, occlude that nostril and now they can't breathe. All right, so I inspected my nostrils. It said there was no trauma. I don't see anything visually, so I'm going to select this. Well, it's to my right, but it's the patient's left nair. I'm going to select my NG tube, my feeding tube. Generally, 14 to 16 French is the normal that is stocked on the units. It would be for a normal adult person. They come in much, much smaller tubes, the smaller the patient is. I'm going to measure then to see how far in we're going to go. And I go from the nair here. All the way down to the xiphoid process. Okay. Nair, earlobe, xiphoid process. And so wherever my finger is, I'm actually going to mark with my pre-torn tape my goal of insertion. That will tell me how far to go in on this patient, okay? Next thing I'm going to do is lubricate my first 4 inches. I just poured some lube in a bag and here we go. You'll have actual probably little packets of jelly. There are some hospitals that use a type of like lube, what do you call it? Xylocaine, lidocaine solution gel that you can spray in the nair a couple hours, or excuse me, not a couple hours, about 20 minutes before you put in this tube to try to get rid of some of the discomfort. All right, so I lubed the first 4 inches. Kind of follow your check off very quickly. We're going to insert the tube through the nostril to the back of the throat, aim the tube towards the back of the throat and down. Okay, so the patient should be sitting up. They can be in a slight sniffing position for this first part, if you'd like. And you're going to aim it actually kind of pointing right at the septum. It works a little bit better if you let the center septum guide you. So I'm going to go down until the patient gags. Okay. There is a method, and we instructed you in your checkoff to do this, but if you have a cup of water, if you want to make sure you're actually in the back of the throat, you can take a pen light and look. Oh, I see it dangling there. All right, Mr. Jones. So the next step, I'm going to have you take small sips of water. It will help the tube go down. Excuse me, fumbling here. All right. So we're at the back of the throat. I have a cup of water. If I have an assistant, they can help me with this piece. They can help the patient hold the water. And as the patient is swallowing, you position the head forward a little bit. So I'm going to show you on me. Moved forward. And what that is doing is now I'm protecting my airway. So it's important for this piece, especially if your patient is not completely conscious and they can't protect their own airway. They're not going to have that big cough, that very scary protective cough when you go down the airway. So you need to push the head forward a little bit like this. So on this patient like this, boop. As the patient is swallowing, you guide the tube down the nose, push it in with gentle, steady pressure. The swallowing motions help the peristalsis and move it along. And I go to my tape. That's how I know I'm at my goal. Okay, now we can plug the tube. Make sure that the tube is plugged here. And temporarily anchor tubing. So I'm going to show you how I do that. Here. Generally beforehand I will have my tape already, but if you use this silk tape, it's easier to cut. So this is too big. Getting rid of that. You take a little piece of tape like this and make a Y. You see that? So to temporarily anchor it, you put this piece on a clean nose. You will probably, especially if the patient has been febrile, have to wash with soap and water. And here I am temporarily anchoring it. So why do this piece? Why temporarily anchor it? Well, because I am not sure it's actually in the right place. They've done some things to make sure I try to get it in the stomach, but I don't know if I'm above the stomach or if I went too far into the stomach. I don't know if I got into the lungs. So you have to have chest x-ray confirmation. It's not good enough to assume. You cannot start food, fluids. Don't attach this and give your bolus feeding until you have the doctor's order that it's okay to use. And they get that after you see a chest x-ray confirmation of placement. It's the gold standard, and you have to get it upon insertion. There's no workarounds. There's no alternative. You must have the chest x-ray confirmation. Okay. So once we get the portable chest x-ray to confirm placement, now we can do the official anchoring of this product. So there's a couple of things we can do. You can leave this or remove it. It totally depends on your hospital policy, but you should note if I got the notification, hey, it's okay to use, I should note the number at the nair, the number right here. There's marks on this thing that tell me how far out it is. And another thing I can do, especially if I have a old type of feeding tube that doesn't have numbers, is you could use the centimeter side here. Let's see if I have it on here. Okay. And measure from the nair out to the end. And I can read off that it's about 630 centimeters, or you can say it's 25 inches. I want to know what it is from the nair to the end so I can check that. I'm going to use a nasal product to hold it officially in place for a few days. This one's called a Statlock Nasogastric. It has directions on it and there's skin prep on it. It's actually attached to this kind. It's a good reminder that you should prep the skin. You should cleanse it with water and soap, dry it, and apply some sort of product. Some people use that povidone iodine. Some people use skin prep. So you may try a few things, use what other people use at your hospital. But here's the product that I'm practicing with and we have in our skills lab, okay? I secure one end here to the nose. My tape is still at the nair. And then this other part wraps around. Excuse me. Okay. So that's one way. And then you may, for a secondary anchor, take a little Tegaderm and secure it to the cheek. Let's see if this will work. There we go. There's also a pink type of non-allergenic tape you could use. I didn't find any in our skills lab today, but with children especially, you need to have some sort of secondary device, secondary securement, and it should be non-allergenic for their skin, hypoallergenic. So we've got the securement above the nose, we've got the Tegaderm to the cheek. Careful with that Tegaderm, you don't want it sticking up in their eye. That can be extremely irritating, I'm sure you can imagine, or even right next to the eye, you'll feel like there's something in your peripheral vision. So try to keep it down on the cheek a little bit. That is it. It is clamped. Once I get the okay to use order from the physician, I can open and attach to the feeding device. I'm going to show you how we attach. We have something called a Lopez valve. And we'll stick one in here. And this other end will actually go to your feeding tube. So your bag of feeding has an end that's just like that will stick in the top here. Okay. So if it's off right now, I would turn the dial to off towards patient. If the feeding is on, I would make sure the off button was, move this closer, excuse me. Here you go. So this is patient side, this goes to the tube feeding. If the tube feeding is off, let's say they're going to procedure, their NPO for procedure, you would turn this dial off to the patient. And that means the tube feeding is blocked through here. It's not going to go into the patient. If you have the tube feeding on, see arrow, arrow, that's open. That means it can go into your patient. When you're giving meds, you'll likely get really good at holding this in one hand and flipping this dial, okay? Because, as you can imagine, don't do that in hospital. Here's your medication syringe, let's pretend, okay? Got a medication syringe. I've pulled up my med. I'm about to give it to my patient. The easiest port to give it to my patient is here, but I don't want them to, if I open this and the tube feeding's going, it'll come all out. So what I generally do is I turn it off here. I take off the cap. This is the med, remember, I attach it. When it's ready to go to the patient, I turn this dial off to the tube feeding because look, arrow, 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 it's gonna go into the patient. And I put it in at a slow rate of speed, tap it in, make sure that it's slow, you're not shooting a bunch of contents into that stomach, okay? Well, now I want to take this syringe off, but if I just go like this, all my med's going to gurgle out. So I turn off to either this one or to the patient, probably this one, and put my cap back on. You get my flush solution. It's off to my med port. I'm going to attach this off to the feeding, turned on towards the patient. See the arrows, boop, boop, and flush it. Okay, turn off. As I remove the syringe, put on your cap. This cap is the bane of my existence when it comes to skincare. It has a tendency to fall off and just go by gravity into one of the skin folds. And you can imagine to have that sharp edge against your skin anywhere in the bed. So if it is missing, you need to sweep the bed for it. Make sure your patient's not sitting on it because they'll get a skin tear, skin injury from that. All right. So we've done a second anchor. We've kept head of bed elevated at least 30 degrees. And then I really do want you to consider, and you will do this in your checkoff, oral care. You need to provide oral care. Remember, you just stuck something through there. You have lube that went through there. You could have had xylocaine that went through there. Please offer oral care. Imagine this is a patient with an intestinal obstruction. Maybe they've been vomiting some bile, some stool content, even if they're really backed up. We want to take care of that mouth. Another thing to consider why oral care is so important in these patients with NG tube care is because when you have something in your nose, patients have a tendency to start breathing through their mouth more, which would cause a drier environment. In order to promote some mouth moistness, it's also a good idea to get in the habit of providing oral care to our NG tube patients. After I'm done with everything, I can dispose of supplies with gloves on. I'm going to document the NG tube insertion, tube size, how I did my placement checks. Number one needs to be chest x-ray confirmation. Gastric secretions color, because while you put this in, you'll probably have seen quite a few gastric secretions come out. That doesn't mean I'm actively pulling them, but I should notice, oh, it's a yellow color, thin, or it's green. It tells us it's more of a bilious content. It could be light brown, could be red. That would be a problem. Type, amount, client's response. Definitely want to make sure they didn't desat during this process. There are some clues that we have if we put it in the wrong spot. Patients have a natural tendency to protect their airway. So if you accidentally put it down the lungs, down into the lungs instead of the stomach, chances are they'll desaturate. Also, you would have tachypnea, tachycardia, possibly, what else? Oh, yeah, desaturation you would notice. But the chest x-ray confirmation is still what we need. You cannot assume that you did the right thing. We are not x-ray eyeballs yet. So that is all I have for you. Good luck studying. Send us questions as they come up. Thanks, guys.